Hello everyone. Is my voice coming to everyone? Please let me know in the comment section. Thank you. Good evening everyone. Welcome to Pediatrics by Dr. Anand. And today's topic of choice, we're going to talk about a very beautiful topic, cardiology. It takes, it takes around 1 to 2 minutes for the buffering for the whole video. That's why I am also same live at exact 8:30 p.m. But usually sometimes it takes, 2 to 3 minutes to buffer the whole video. Let's start this beautiful class. Is my voice audible to everyone? Yes or no? Please let me know if my voice is audible to everyone. Let me just check 1 second. Hello, Dr. Osama. Yes. Yeah, I think its voice is coming now. Let's quickly start this class. Hello everyone, welcome to Pediatrics by Dr. Anand. I am Dr. Anand. I have done my MBBS from Bangalore. I have done my MD from Tirthankar Mahavi University, Uttar Pradesh. Then also I'm working as assistant professor in a medical college with a beautiful teaching experience to all the UG and PG students. Also, we have batches for UG, PG and MD and MRCPCH students. Today's batch we has for the people who are applying for NEET PG and for the INI-CET. Before starting, like today's topic of choice is going to be congenital heart disease. I hope my voice is audible. Yes. Good evening, Dr. Shubham. कैसे हैं? क्या चल रहा है? क्या चल रहा है, bro? Yes, exactly. Hello, everyone. Yes, okay. Orion, great. Is my voice audible to everyone? Yes, exactly. Bird भी आएगा. अभी चिड़िया घर आएगा पूरा का पूरा. Okay, let's start this beautiful class. Hello, Dr. Amarnath, Priyanka, Grace, Lina, Paul, Faizan, Raza, Monimala, Suman, Osama, Sheikh. So many people. Good evening, everyone. Okay, let's start this class. Before starting any amazing segment, we always have a motivating quote, and today's motivating quote is very important. Don't lose focus. My only request by holding my hands to all of you, don't lose focus. Life is amazing. Life is beautiful. You will get the seat. You will get your dreams. You will get whatever you want to wish. All you have to do is believe in yourself that you were born to rock and you are rockingly amazing. So don't lose focus. Don't lose focus. Remember that. Yes, Dr. Shubham, I'm really good, bro. मैं ठीक हूँ, bro. आप कैसे हो? क्या चल रहा है, Dr. Shubham? जैसे तेरा आता है ना नाम, तो पहले मैं अपने बाइसेप्स का इंच थोड़े बढ़ा लेता हूँ, ठीक है? क्योंकि the class should be good in every aspect. The quality content, the quantity content, and every single content. So remember, guys, exactly. Yes, don't lose focus. Life is beautiful. Okay, let's start this beautiful class. Yeah, so now in this segment, it's a very beautiful segment with some new amazing questions. I have taken from all the closest amazing books. I have taken the cardiology. Our target is to finish cardiology in the next 10 days, and with all the amazing MCQs from A to Z. The causes of radiofemoral delay. Can you please answer me, what are the beautiful causes of radiofemoral delay? Dr. Vaibhav, Dr. Indian Lovers, Vedahi Pandey. Now please, good vibes. Again, we have 100 students back to back. So, and how is this color? Do you like the color of this one? I've changed little color. Is this beautiful, the background color? Please let me know. The previous color was fine, or this color is little attractive? Let me know. Exactly. Now, as we are talking about cardiology, so you know that very importantly, the radiofemoral delay, right? Bounding upper limb pulses and very feeble femoral pulses. Yes, beautiful. Yes, exactly. So yeah, the answer is nothing but coarctation of aorta. Beautiful. And other than coarctation of aorta, can you please tell me one more example of radiofemoral delay? Anyone? Yes, anyone? What about that? Do you remember the large vessel, medium vessel, and small vessel vasculitis? What were the large vessel vasculitis? Can anyone answer in the comment section? Large vessel vasculitis. Can anyone please answer me the large vessel vasculitis? Anyone? Exactly. Have you heard of Takayasu arteritis? Yes or no? So two important causes. Yes, exactly. Okay. Yeah, okay, fine. Dr. Monimala, okay, cool. I'm gonna change the color also. Don't worry, it's mix of colors. Let me know your beautiful comments and compliments. I'll get it. So, so now that the first MCQ which I could able to appreciate in Dr. Anand's classes is the causes of radiofemoral delay are nothing but coarctation of aorta and Takayasu arteritis. Coarctation of aorta and Takayasu arteritis, two are important condition. These are important for clinical based questions also, because this is what question examiner had asked me. It's a very common question, the causes of radial delay and radiofemoral delay. The causes of radiofemoral delay are coarctation of aorta and Takayasu arteritis. Next important question you have, what is the normal blood pressure of a 4-year-old child? Can you please guess the best answer? One of my favorite students, Osama Sheikh. Yes, let me know. Every time I get message, whenever some new student join my WhatsApp group, they always, just now I got a message. I saw your videos on YouTube. They are really inspiring. Ooh, sounds nice. Inspiring is a good word. I feel good. What is the normal blood pressure of a 4-year-old child? Can we please answer in the comment section, please? Do we have a formula for the expected systole and diastole? Yes or no? I hope you know that. So 90 plus age into 2. 90 plus age into 2 for systole and 55 plus age into 2 for diastole. 90 plus age into 2 is the formula for expected systole and 55 plus age into 2 is the formula for expected diastole. This is the 90th percentile blood pressure of a 4-year-old child. So basically 90 plus age into 2 for systole and 55 plus age into 2 for diastole. The answer for this question comes as 98 by 63. 98. Anyone has given a beautiful answer? Koi hai mahan hasti? Okay, Shubham. Okay, Monica, Grace, Manish, Amrit, Vaibhav. Yes, exactly. So the 90 plus age into 2. 90 plus 8 is nothing but 98 and 55 plus 8 is nothing but 63. 2 questions back to back over. Question number 1 was, so now, okay, listen very carefully. Good vibes. I want strong positive vibes. Full aura should be like crazy, beautiful, positive vibes. 2 beautiful questions I was able to understand. What are the causes of radiofemoral delay? The answer is coarctation of aorta and Takayasu arteritis. And the blood pressure of a 4-year-old or any year-old child, we have the 90th percentile target, 90 plus age into 2 for systole and 55 plus age into 2 for diastole. Next important question, calculate the heart rate of this patient. A beautiful ECG question. Can anyone answer in the comment section? If I don't tell you the answer, if we take these two, okay, I'll not tell you. Can you please tell me the heart rate of the patient? ECG is in front of you. You have 10 seconds. Tell me the heart rate of this patient. Quick answer, quick. Just 5 seconds, tell me, and then I'll tell you whether you're right or not right. So quick answers, please, anyone? Yes, very good, very good, very good. Very good, perfect. Okay, yes, that's right. So 9, anyone? Okay, so Dr. Indian Lover says 60, Amrit says 75, Priya says 75, someone says 60. How do you know, sir? I am a new student to Dr. Anand classes. Could you please tell me exactly how did you calculate for this the heart rate? Yes, exactly. Please remember, very, very, very important. Yes, 1 second. Yeah, exactly. So please remember one thing. So you know that, right? This is P, Q, R, S. Yes or no? So most importantly, one important thing I need to remember is please RR interval. Now this is really important. This is the R and this is the R. You need to calculate the RR interval. Do we have the formula? Yes, Dr. Suman is very right. So always remember one thing, the formula, we have multiple formulas actually. At least for this class, the important formula is 1500 upon number of small squares in RR interval. This is the formula for the heart rate. Listen very carefully, 1500 upon number of small squares in RR interval. Which is the RR interval? This is the PQ, this is the R, okay, and this is the S, and here also P, Q, then R. Can we appreciate this one? So basically from this part to basically this part. So you know that, right? So this is one box, and one box contain how many small boxes? 5, right? This is another box, it contains another 5, very important. This kind of a 4, and extra I'm counting here is 1. So basically 1 box, 2 box and 3 box roughly, and yeah, 5, 5, 5, and one more we have is over here 5. So total how many boxes over? Exactly, can you please answer it in the comment section? Yes, very good, beautiful one told by beautiful people. So heart rate basically 1500 upon number of small squares. So basically 5 plus 5 is 10, then we have 15, and then we have 20. Total 20 are there, the small boxes. 5 plus 5 plus 5 plus 5. Total 20 small boxes are there. Can we appreciate this? Yes or no? That's why 1500 upon 20 is the best answer, and 75 is the best answer for this question. Has everyone understood this much? Yes or no? This is really very important question, because today I was thinking to teach you not just the theory. I wanted clinical question. I was thinking thinking what clinical question should I ask my beautiful students. That's why I just thought of asking them expected blood pressure, please look at the ECG and tell the heart rate. These could be the very front end questions for the next students basically. Has everyone understood this much? Yes or yes or yes, please let me know. Okay, 1500, the message right now which I should appreciate is 1500 upon number of small square, 1500 upon number of small squares between RR interval, between the RR interval. 1500 upon number of small squares in the RR interval is a very simple and very easy formula to calculate the heart rate of the patient. I assume everyone knows this. Now we can continue with that from the further questions. Okay, yes. Now the next question is very important. Which criteria do you use to diagnose the presence of a congenital heart disease? Simple, beautiful question. Let's just finish it off. Yes, what is the name of the criteria? Dr. Osama, Dr. Shubhangi, Swaraj, Suman, Nancy, Vaishnavi, Vaibhav, Manish, Indian lovers, Vedhi, Shubham, so many people. Yes, beautiful people. So the name of the criteria we have is NADA's criteria. NADA's criteria, and everyone knows about it. We have the major criteria and we have the minor criteria. Yes or no? Major criteria and the minor criteria. Can you please tell me? I have a question. I am a FMG student. I need to know, when will we say NADA's criteria is positive? Like how many major and how many minor criteria should be positive if I have to say it is a NADA's criteria? Can you answer in the comment section, please? Very good. Can you answer in the comment section how many major and how many minor criteria should I fulfill to say that this patient has some congenital heart disease according to NADA's criteria? Yes, very beautiful answer. Can we please remember 1 plus 2? Yes or no? Very easy one. 1 plus 2. 1 major and 2 minor. 1 major and 2 minor. Exactly. Vaibhav, very good. Vaibhav Sharma. Vaibhav Sharma is these days he's coming to our classes and he's answering good. Dr. Suman, not 2 1, 1 plus 2, 1 plus 2, 1 plus 2 is easy. I hope it's not difficult to remember. Exactly. So NADA's criteria, 1 major and 2 minor. I would like to say this is a positive NADA's criteria. And can you please answer now in the comment section, what is the major criteria? Can you please tell me what are the important points of major criteria? There was some CC. Do you remember that? So basically, can you tell me? Okay, we have a systolic murmur. Systolic murmur, number 1. Systolic murmur, which grade? Can anyone answer in the comment section? Do you remember roughly we had 4 criterias in the NADA's criteria? The major one, C for cyanosis, C for congestive heart failure. Systolic murmur, which grade? Anyone? Which grade you will say that it is a major criteria? Anyone? And very important, any diastolic murmur. Any diastolic murmur. I'll repeat again. Systolic murmur grade 3 or more. Any diastolic murmur, cyanosis and congestive heart failure is the important, yes, is the important points for the major criteria of the NADA's criteria. I'll repeat again. We have the major criteria, we have the minor criteria. In the major criteria, as I told you, systolic murmur grade 3 or more, any diastolic murmur, patient having cyanosis and congestive heart failure. I would like to say the patient has, these are the important major criteria. Okay, remember guys, learn, revise, finish here only. Okay, learn, revise, finish, learn, revise, finish. Okay, Osama, very good. Osama, grade 3 or more, okay. So I'll repeat again, what are we studying? To diagnose a congenital heart disease, the patient must, fulfill the NADA's criteria. What is NADA's criteria? We have the major criteria and we have the minor criteria. In the major criteria, we have systolic murmur grade 3 or more, any diastolic murmur, any features of cyanosis and congestive heart failure. What about minor criteria? Yes, Dr. Suman, please can you tell me the minor criteria quickly, and please quickly, what are the important points of the minor criteria? It's very easy, my dear. See, systolic murmur grade 3 or more, right? It was in major, right? So you can write, no, systolic murmur basically less than grade 3. Yes or no? Systolic murmur which is less than grade 3, very important. Any abnormal S2 sound, any abnormal second heart sound, very importantly. If the patient has an abnormal ECG, abnormal chest x-ray, and abnormal blood pressure. These are the beautiful points. Yes, Priya Gupta, very good, Priya. People who are answering in the comment section, no, they are like very good, really very good. That's how you will remember that. Okay, Exactly, very good. Dr. Suman is answering. Then she's giving a heart, congenital heart. Very good. That's what it's. Is it? Are you able to understand, my dear? So, what are the minor criteria? Systolic murmur less than grade 3, abnormal second heart sound, abnormal ECG, abnormal blood pressure, and abnormal chest X-ray. This is what I should remember. Very importantly, systolic murmur less than grade 3, abnormal second heart sound, abnormal ECG, chest X-ray, and blood pressure. These are the minor criteria. That comes to a straight away very important question: how many major and how many minor, which we have covered. Can you answer in the comment section, please? A, B, C, D. Which option would you like to choose, guys? A, B, C, D. I've already told you the best answer for this question is one major and two minor. So 1 plus 2, right? 1 plus 2 is a very simple answer. Yes, Indian lovers, very good. Faizan Raza, हाँ जी, ब्लैक वाली टी शर्ट भी मैं लाऊंगा, मैं पक्का मैं आपको वो करूंगा, टेंशन ना लो, ठीक है? Yes, very good. Dr. Manish Yadav answering so beautiful. Manish is a very good student. Yes, one major and two minor. I hope this much is very easily comfortable to everyone. Has everyone understood this much? Yes or no? Please let me know. So that's what. Let's have a quick revision. What did we study in this class? Sir, in this class, most importantly, you told the various causes of radio or femoral delay, which was nothing but coarctation of aorta and Takayasu arteritis. Then, sir, you told me the abnormal the blood pressure expected is nothing but 90 plus age into 2 for systole and 55 plus age into 2 for the diastole, 90th centile. Then also you told me that to calculate the heart rate of the patient, the formula is 1500 upon number of small scares in the RR interval. Then also after that you told the name of the criteria to diagnose a congenital heart is NADA's criteria. 1 plus 2 is something we need to remember. This was the major and this was the minor criteria. 1 major and 2 minor. This is what I would say, it is a positive NADA's criteria. We have covered around 10 questions we have covered now. Has everyone understood this much? Quick like button so that I can move further. Anyone? झूमेगा आसमां, गाएगी ये ज़मीं, मैंने सोचा न था. Yes, what are the grades of murmur? यहाँ हम इतनी सारी बातें कर रहे हैं. Lot of talking you guys are doing. Systolic murmur grade 3 or more, systolic murmur less than grade 3. I have a doubt. I am a student. I have no idea how many grades of murmur are there. How many grades of murmur are there? If I ask you a question, these are the 5 options. Can you please tell me how many grades of murmur are there? Dr. Rupa, Dr. Amrit, yes, तुसी great हो. Amrit कह रहा है. Amrit, you are also very good, yaar. You are a JR in our PEDS department. That's very good. MD pediatrics you're doing. That's an amazing. Indian lover says, sir, please sing तेरी गलियां. तेरी गलियां का सुर मेरा भी पक्का नहीं है, मैं एक बार लर्न करके I'll tell you. Okay, Ashok Sharma, perfect. So how many grades of murmurs are there? Can you please tell me? I really forgot. I have no idea how many grades of murmur are there. So basically there are 6 grades. There are 6 grades of murmur. That is the first question. Total there are 6 grades of murmur. Second question, there was recently, it was there in the INI-CT paper. Which murmur is moderately loud with a palpable thrill? Nice question. Which murmur is moderately loud? We have a lot of grades, right? We have 6 grades of murmur, right? We have 6 grades of murmur. So can you please tell me which grade of murmur basically is moderately loud with a palpable thrill? With a palpable thrill. Any quick answer? A, B, C, D. What do you think? If you have to randomly guess one answer, what will you say? किसमें मिलता है? Which murmur you will see, you will get palpable thrill. So basically, most importantly, you get in grade 4. In the grade 4 murmur, yes, exactly. Perfect, very good. C is the best option. That's very well put. Yes, exactly. तेरी दीवानी कैलाश खेर का गाओ सर जी. कैसे गाऊं मैं? तू इधर आ, तू मेरे साथ बैठ के गाए, काम दोनों साथ में गाते हैं, ठीक है? So basically, how many grades of murmur are there? Please, this is a very beautiful take-home message. Number 1, there are 6 grades of murmur. Okay, very important. So please remember, we have the grade 1. The grade 1 murmur is a very faint murmur. It only be heard by an expert. Okay, please, good vibes, strong positive vibes. We are reading the grades of murmur. I would like to revise, learn right now, right away the full thing of grades. What is the grade 1 murmur? Grade 1 murmur is a very faint murmur, only heard by an expert. Number 1. Number 2, we have the grade 2 is a soft murmur, and grade 3 is a moderately loud murmur. I'll repeat again: very faint murmur, soft murmur, moderately loud, and loud. Can you revise this for me? What was that? Grade 1 is very faint murmur. Grade 2 is soft murmur. Grade 3 is moderately loud, and grade 4 is loud murmur associated with a palpable thrill. Very, very important. Associated with a palpable thrill. It happens in grade 4. In grade 1 there is no thrill. Grade 2 no thrill. Grade 3 no thrill. Grade 4 we have a palpable thrill. Okay, very importantly. Okay, so I'll repeat again. Yes, very importantly. Yeah, grade 1 murmur is a very faint murmur. Grade 2 soft. Grade 3 moderately loud. Grade 4 loud with the thrill. Grade 5 is very loud, and grade 6 is the loudest. Very easy. Yes or no? Very loud and the loudest. So basically that's what in the grade 5 murmur is a very loud murmur heard with the stethoscope partially off the chest, whereas grade 6 murmur is the loudest murmur. You know, it is heard with the stethoscope entirely off the chest, entirely off the chest. So just in general, this is like a basic rough scale. If I talk about, I would like to comment on the grades of murmur. Just one thing you remember, that which murmur from which grade you get the palpable thrill. The answer is grade 4. So very faint, soft. Grade 3 is moderately loud. Grade 4 is loud with the thrill. Grade 5 is very loud, and grade 6 is the loudest. Yes, exactly. Yeah, everything is same for me. Yes, but remember, grade 4 is palpable thrill. That much I want you guys to remember. Very smart question. AIMS 2018 question. Now we are coming to entering in a very, very smart project of cardiology. In the right to left shunt, which finding are you expecting? Very smart question. Can you please answer in the comment section, please? Which finding are you expecting? You might expect. Anyone? Answer in the comment section, please. Anyone, please, quick answers. You have 5 more seconds. Yes. Very good. जाने जान ढूंढता फिर रहा तुम्हें रात दिन, मैं यहाँ से वहाँ, मुझको आवाज दो छुप गए. Yes, that's right. So the best answer for this question, yes, Dr. Osama ने बिल्कुल दावे से के साथ कहा है, the best answer for this question is elevated hematocrit level. In a case of right now, this is something I have to understand. Okay, you cannot cram this question. You must have a rationale for this. So right to left shunt, which finding are you expecting? Option number A, will you find an increased URTI and LRTI? क्यों? Cake? Will you find a increased URTI and LRTI in a case of right to left shunt? The answer is no. You are in more URTI, more LRTI basically you find in a case of left to right shunt. In a case of left to right shunt, you will find increased URTI, increased LRTI, increased hospital admissions, right? But why exactly? Why will you find elevated hematocrit level in a case of right to left shunt? Because point number one, see, let's learn. Okay, it's very easy. Number one, in a case of right to left shunt, very importantly, right to left shunt will be a cyanotic or a acyanotic. Right to left shunt, it will be a cyanotic problem or a acyanotic problem. Can anyone answer in the comment section, please? Yes or no? Right to left shunt, right? If I am saying anything which is right to left, it has to be some pulmonary stenosis. Do you agree? Yes or no? If I'm saying a right to left shunt, then naturally I assume that lungs are not available for the oxygenation. Do you agree with this line? Yes or no? If I'm saying a patient having right to left shunt, I assume that lungs are not available for the oxygenation, and basically the patient will land up into cyanosis. So once the patient land up into cyanosis, the patient will have hypoxia. Are you understanding? Yes. More right to left shunt means naturally more cyanosis, and there will be naturally more hypoxia due to cyanosis. And whenever I'm suffering from hypoxia, very important, there's a compensatory increase in the hemoglobin. hemoglobin. There is compensatory increase in the hemoglobin. That's natural, right? If my body is having hypoxia, then naturally, the oxygen carrying capacity is less, so my hemoglobin will increase. Once my hemoglobin will increase, naturally I will have polycythemia. When my hemoglobin content increases, my packed cell volume, or I would say the hematocrit, or I would say the viscosity, the thickness of the blood basically increases, and the baby land up into secondary polycythemia. Now, this is a very important question, that a patient having right to left shunt will definitely have some polycythemia issues, because right to left shunt mean naturally cyanosis. Whenever there is cyanosis, there is hypoxia. Whenever there is hypoxia, naturally there is a compensatory increase in the hemoglobin. No, my body needs to breathe, right? It needs oxygen, right? So more and more hemoglobin will form naturally. That will lead to more and more hematocrit production. That will lead to thickness of the blood will increase, viscosity of the blood will increase, and that is known as secondary polycythemia. Secondary means, very importantly, secondary means due to underlying problem, like because of hypoxia the patient got polycythemia, because of dehydration the patient got polycythemia. This is secondary, because we have primary polycythemia and secondary polycythemia. Primary polycythemia is known as polycythemia rubra vera, whereas secondary polycythemia is because of any injury, any insult. So that is the best answer, that the patient having right to left shunt will have an increased hematocrit level, whereas patients who are having left to right shunt, they will have increased URTI, increase LRTI, and increase hospitalization, increase hospital stay. Do you agree with this line? Yes or no? Has everyone understood this much? Put a like button. समझ में आई कहानी या नहीं समझ में आई? Exactly. Very good. Are you understanding? If I'm having a left to right shunt, means increased pulmonary blood flow. If I'm having increased pulmonary blood flow or nothing but plethoric lung fields, then naturally my lungs will be affected more, and the patient, I will have more LRTI, chest issues, more pneumonia, and more hospital stay. This is in left to right shunt. In a case of right to left shunt, I will have polycythemia, secondary polycythemia. समझ में आ रहा है? Has everyone very beautifully understood this part? Please let me know so that I can move further. Yes, exactly. Okay. Yes. Very good. Very good. And Dr. Osama, one of my very favorite junior, Dr. Osama, has told a very beautiful line. Can you please tell me what is this definition of neonatal polycythemia? When I'm telling because of hypoxia there is more hemoglobin, there is more hematocrit, what is the definition of polycythemia? Can you answer in the comment section, please? Yes, exactly. Anyone? Yes, very good. So the definition of polycythemia is nothing but hemoglobin more than 22 gram per DL, hemoglobin more than 22 gram per DL, and hematocrit level more than 65% at day 1 of life. Are you understanding? Hemoglobin more than 22 and hematocrit more than 65 or at day of life 1 in a newborn baby is known as polycythemia. This is a very important exam question, and I have told this multiple times, and very beautiful. This answer has already told very well by one of my favorite junior, Dr. Osama Sheikh. ये ओसामा के बाल हैं यहाँ पे, थोड़े से बाल हैं यहाँ पे, ठीक है? Okay, great. Okay, I assume everyone has understood this much. Okay, how do you measure? As in, no, there is no specific criteria for measuring. I'll let you know, Orion. That's a separate thing. I'll let you know later. I hope you have understood this much. Yes or no? Let me know. समझ में आया? Yes. Okay, exactly. And this part we have already covered. So there are so many syndromes now. Cardiology is all about syndromes. Okay, now quickly I'll ask you 5 questions, just basic 5 questions I'll ask you. You have to tell me which congenital heart is common in that. Which is the most common congenital heart disease in Down syndrome? Can anyone answer in the comment section, please? Which is the most common congenital heart disease in Down syndrome? Quick answers, please. Yes or no? The most common. Exactly. Perfect. Indian lovers, great. Dr. Wazahat Arif, great. Okay. Yes, Dr. Suman says, nice haircut, Osama. This looks like a flag sign. Yes. And where do you see flag sign? The flag sign you see in a case of क्वेश्चर वो होते मोटे हैं, but they have apathy, remember, okay? Yes, exactly. The most common congenital heart disease in Down syndrome is the atrial septal defect. That's perfectly right. Okay, which is the most common congenital heart disease in Holt-Oram syndrome? In the further classes, we're going to talk about, I'm going to show you all the crazy syndromes in cardiology, because cardiology are very importantly associated with syndromes. So let's just finish it off. Which is the most common congenital heart disease in Holt-Oram syndrome? Can anyone answer in the comment section? Yes, exactly. Perfect. The most common congenital heart disease in Holt-Oram syndrome is also a atrial septal defect. The most common congenital heart disease in Down syndrome is a atrial septal defect. The most common congenital heart disease in Holt-Oram syndrome is also a atrial septal defect. Can you tell me one more syndrome? Now this is a good question. Dr. Faizan Raza, Suman, Manish and Wafa Hussain, can you please tell me do we have one more syndrome where the most common congenital heart disease is atrial septal defect? Let's see if you can answer anyone. हाँ जी, डॉक्टर शुभम बेटा आंसर करो. आंसर तेरे को ब्लॉक कर दूंगा, वरना तू आंसर दे पहले बेटा. बेटा घर पे आके बताना तेरे को मैंने अगर आंसर नहीं दिया तो. एग्जैक्टली. विच टेल मी वन मोर सिंड्रोम वेयर द मोस्ट कॉमन congenital heart disease is atrial septal defect. We have done this before. One is Down syndrome, one is Holt-Oram syndrome. Anything else? Exactly. Can I say Rubinstein-Tybee syndrome? Rubinstein-Tybee syndrome, yes or no? Can I say that? Have you heard this? गलती से भगवान के लिए नाम सुना है कहीं पर किसी ने अपने घर पे? Rubinstein-Tybee syndrome. We have done that in the previous classes. Can you please tell me what are the important points of Rubinstein-Tybee syndrome? Exactly. Can I write broad thumbs? Can I write broad thumbs? See, I don't want you guys to remember every single thing, okay? But at least what I expect is that you must remember that about at least two or three important peculiar points which are specific for that syndrome. Broad thumbs and great toe deviated. Broad thumbs and great toe deviated. These two important points are only and only there in the Rubinstein-Tybee syndrome. There is not even there is no other syndrome where you see broad thumbs and great toe deviated. It is only and only Rubinstein-Tybee syndrome where you see broad thumbs and great toe deviated. And the other random points, you can tell me low set tears, you can tell me developmental delay. Developmental delay is in everything. Developmental delay is in everything. And for the extra mark points, microcephaly. You see microcephaly in a case of what you called in a case of Rubinstein-Tybee syndrome, you see microcephaly. Do you remember the last week class I told you the causes of microcephaly? Has everyone remembering? Remember I told you Rubin and Smith family were crying because they wanted to eat corn at Pattaya beach. We have done that mnemonic. I hope you guys remember a little bit of it. I don't expect you to remember everything, but at least a little bit of it. Yes or no? Do you remember? Yes or no? The Rubin and Smith family, Rubinstein-Tybee syndrome, Smith-Lemli-Opitz syndrome. Rubin and Smith family were crying. Cry-do-chart syndrome. Why they were crying? Because they wanted to eat for Edwards syndrome. They wanted to eat what? Corn. Cornelia de Lange syndrome, which is known as Amsterdam dwarfism. So Rubin and Smith family were crying because they wanted to eat corn at Pattaya beach. So Patau syndrome. These were the important, crazy, difficult causes of microcephaly, and we have done each syndrome with depth and detail in the previous classes. Has everyone understood this much? Let me know. Yes or yes. Yes. वो कौन है जिसका मैं हूँ दीवाना? Exactly. Perfect. I hope you guys have got it. Okay. Perfect. Very good. Perfect. Very good. ठीक है. तो okay, perfect. So Holt-Oram syndrome is done. Down syndrome is done. I have one more question. Allegili syndrome. Allegili syndrome. Can anyone please tell me which is the most common congenital heart disease in Allegili syndrome? Quick answers, please. Okay. 45 minutes are over in this class. Just 10 more minutes. ये bird बड़ा प्यारा है. Did you saw the origami? Yes, exactly. Okay. Allegili syndrome, the most common congenital heart in Allegili syndrome is anyone please? The most common congenital heart in Allegili syndrome, who will tell me? Yes, the most common congenital heart disease in Allegili syndrome is Pulmonary stenosis, pulmonary stenosis. See, revise, okay, revise million times, revise, 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 revise. There are so many questions we have already done before, but out of 10 you are able, see, in the beginning, out of 10 you will able to answer me 10%, 20%. So I'll ask you again, then 30% you will answer back. Then if I ask you again, 50 to 60% you will try to answer the questions back, right? There should be a time I asked you anything, 99% you should be able to answer me back that, sir, the answer for this question is that. Exactly. Yes, Dr. Osama is right. Alagille syndrome, the most common congenital heart is pulmonary stenosis. Alagille syndrome, you see butterfly-shaped vertebra, and Alagille syndrome is a very important example of short trunk dwarfism. Short trunk dwarfism. One more congenital heart is important for the NEET students. Williams syndrome. Can anyone answer in the comment section which is the most common congenital heart disease in Williams syndrome? 5 seconds. 5 seconds I'll give you. Okay. Oh, Dr. Amrit, very good. Triangular faces, neonatal cholestasis, pulmonary stenosis. I'm proud of you, Amrit. Proud of you. Very good, bro. Very good. The most common congenital heart in Williams syndrome is, everyone knows, I assume everyone knows. The most common congenital heart disease in Williams syndrome is supravalvular aortic stenosis. The most common congenital heart disease in Williams syndrome is supravalvular aortic stenosis. In the upcoming slides, we're gonna come to each syndrome. I'm gonna show you pictures and some crazy questions associated with it. At least for this slide, remember the syndrome, most common congenital heart. Syndrome, most common congenital heart. So the most common congenital heart disease in Down syndrome, Rubinstein-Tybee syndrome, Holt-Oram syndrome is atrial septal defect. In a case of, very importantly, Alagille syndrome is pulmonary stenosis, Williams syndrome is supravalvular aortic stenosis. Oh, let's move further. Let's move further. कौन सा मोड़ आया जिंदगी के सफर में, बस गई तू ही तू अब तो मेरी नजर में, दिल की हर एक धड़कन तुझको पहचानती है, तेरा हो जाऊंगा मैं तू नहीं जानती है. Exactly. So classification of congenital heart disease. Let's quickly finish this also. This is a 5 marks question. Classify congenital heart. See, how do you diagnose congenital heart? The answer is not asked criteria. How do you classify congenital heart disease? In the classification, you see there are, if I talk about simple ones, either you can see there are very beautiful ways of classification, and now I assume you know this much by our just 1 week of cardiology classes. I assume that you have an enormous amount of knowledge where you can very beautifully, what you called, understand the whole thing. So which one is a तो मैंने भेजी है, रोहित को कॉल कर लो एक बार, मैंने नंबर भेज देता हूँ आपको एक बार, मैं आपको व्हाट्सअप कर रहा हूँ नंबर. So basically, very importantly, the classification of the congenital heart disease is classified into, we have right to left shunt and a left to right shunt, and we know it very well. Can you please tell me, name some left to right shunts? So left to right, left to right, left to right. So the various congenital hearts with the left to right shunt are atrial septal defect, ventricular septal defect, and pulmonary stenosis. Yes or no? See, classification of congenital heart disease can be classified into cyanotic congenital heart and acyanotic congenital heart. They can be classified into a left to right shunts and a right to left shunts. The left to right shunts are atrial septal defect, ventricular septal defect, and pulmonary stenosis. And these all are cyanotic or acyanotic. Yes, everyone knows about it. These are acyanotic. These are acyanotic congenital heart disease. And why they are left to right, that also everyone knows, because the left side of the heart has a higher pressure. The left side of the heart has a higher pressure. That is why left to right shunts are ASD, VSD, PTA. So this is the classification of congenital heart disease. So you know that basically. So once again, I'll show you the congenital heart disease classification is divided into acyanotic congenital heart disease and cyanotic congenital heart disease. Acyanotic congenital heart disease we have already covered, that is ASD, VSD, PTA. Cyanotic congenital heart. Cyanotic congenital heart, the mnemonic I have over here is 5 T's. This is a good one. This is the good one. Okay. If in a very busy exam paper, an external examiner suddenly asks you, name some cyanotic congenital heart disease. So 5T. I want you guys to remember this 5 T's. Okay. This is a very old mnemonic, 5 T's for cyanotic congenital heart. Can anyone answer in the comment section? Exactly. Very good. Very good. Vaibhav. Very good. Yes, exactly. शुभम, आप बहुत प्यारे हो. मैं इतना अच्छा नहीं गाता, आप बहुत प्यारा गाते हो. अपनी मुझे सुंदर सी आवाज में एक मीठा गाना मुझे व्हाट्सएप कर दो, ठीक है? एग्जैक्टली, दैट्स ट्रू, द 5 T's आर इंपॉर्टेंट. नंबर 1, वी हैव tetralogy of phalate, we have transposition of great arteries, we have tricuspid atresia, we have truncus arteriosus, and we have TAPVC. Even also we have Epstein anomaly. These are the important 5 T's. Yes, see, Vaibhav is answering so good, very good. So remember at least very quick answers. See, how do you classify congenital heart disease? We have cyanotic and acyanotic congenital heart disease. In acyanotic congenital heart disease, ASD, VSD, PTA. Over. Cyanotic congenital heart disease, TOF, TGA, tricuspid atresia, truncus arteriosus, TAPVC, and Epstein anomaly. Epstein anomaly. These are the important 5 T's with extra Epstein anomaly I have told you. I hope you have understood this much. समझ में आ गया या नहीं आया ब्रो? ये इंपॉर्टेंट है, प्लीज इसको अच्छे से कर लेना, ठीक है? लेट्स मूव फर्दर 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 फर्दर. Okay, yeah, and also some books, in some book they have told that congenital heart disease classification is based on right-sided obstructive lesions and left-sided obstructive lesions. Can you please name me some right-sided obstructive lesions? Anyone? Can you please name me some right-sided obstructive lesions? Yes or no? Please let me know. Yes, very good, very good. Yes, exactly. So right-sided obstructive lesion, very quick answers. Name some right-sided obstructive lesions. Very importantly, can I say pulmonary stenosis? Yes or no? Pulmonary stenosis, is it a right-sided obstructive lesion? Okay, if I say, what is this valve? This is the tricuspid valve. Can I write tricuspid stenosis? Yes or no? Anything else you want to say? Right-sided obstructive lesion. See, this is a very open answer. Please answer in the comment section. Exactly. Can you please tell me the right-sided and the left-sided obstructive lesions? Yes or no? Yes, we have Rohit. Okay, 1 second. Yes, very good, Rohit. You have perfect answer. Can I say Epstein anomaly, where there is a downward displacement of the tricuspid wall? Yes or no? Any other answer? Very quick, please. Very quick. Epstein anomaly. So the right-sided obstructive lesions are, I can say trilogy of Fallot. I can say tetralogy of Fallot. I can say tricuspid atresia, tricuspid stenosis, Epstein anomaly, pulmonary atresia, pulmonary stenosis. These all are crazy right-sided obstructive lesions. इतनी बार ये बात रिपीट हो चुकी है. Midnight 2 o'clock also, in your dreams also, if I ask you name some right-sided obstructive lesion, sir, right-sided, okay, right-sided, okay. If I go from sir, my HOD used to say go from cephal to caudal or top to bottom or bottom to top. Bottom to top, the right-sided obstructive lesions are pulmonary stenosis or pulmonary atresia. Then we have tricuspid stenosis or tricuspid atresia. Then we have Epstein anomaly. Then we have tetralogy of Fallot, trilogy of Fallot. These all are right-sided obstructive lesions. So yeah, so exactly, and we have done this before also. Right-sided obstructive lesions. Can I say these are ductus dependent pulmonary blood flow condition? Yes, indirectly, yes, you are right only. These are ductus dependent. They are duct dependent pulmonary blood flow condition. Like same thing, pulmonary stenosis, tetralogy of Fallot, pulmonary atresia, tricuspid atresia, Epstein anomaly. Has everyone understood this much? I think am I making sense to you? Is it easy to understand? Please put a like button, because I don't want any newcomer or old comer to get carried away that I don't understand these terms. It's very difficult. Has everyone understanding? Like, are we able to appreciate this line that ductus dependent pulmonary blood flow condition means right-sided problems where I'm dependent on the ductus arteriosus are pulmonary stenosis, tetralogy of Fallot, pulmonary atresia, little above tricuspid stenosis, tricuspid atresia. Any problem, any obstruction to the right side, I need a patent ductus arteriosus for the flow of the blood. Is this line clear to everyone? Please let me know. Sometimes I feel that I don't want anyone to miss out because maybe because of the high speed, but we have repeated this multiple times. That's why I'm having a proper flow of speed my words, okay, in this one. Put a like button. Did you understand? Yes or no? 50 minutes are already over. Yes. Yes, exactly. Dr. Osama is right. Even pentalogy of Fallot. Yes. What is pentalogy of Fallot? Quick answers, please. Everyone. I hope everyone knows. Shubham, क्या होता है pentalogy of Fallot? Yes. Tetralogy of Fallot plus what? Anyone? Tetralogy of Fallot plus yes. Tetralogy of Fallot plus atrial septal defect is a pentalogy of Fallot. Pentalogy of Fallot. Right. Great. So what are we studying? What all did we cover, sir? You told told me to diagnose a congenital heart, we have a criteria known as NADA's criteria, where the mnemonic was 1 plus 2, 1 major and 2 minor. Then also you told to classify congenital hearts, we have cyanotic and acyanotic. We have right-sided obstructive lesions or the left-sided obstructive lesions. So yes, exactly, the left side, anyone, the left-sided obstructive lesions, very importantly, left side kya kya hota hai? Left side aorta is there, no? Can I write aortic stenosis? Obviously. Can I write coarctation of aorta? Obviously. Can I write interrupted aortic arch? Do you? Yes, exactly. Do you agree with this line? Yes or no? Yes. Very good. Very good. Dr. Shubham, you are a pro. You are an awesome PhD holder. Very good. Yes. Dr. Sophia, left-sided TGA, left-sided obstructive lesion, I wouldn't say that. Left side of the heart, no, Dr. Sophia. If this is my four-chambered heart, pulmonary artery, and this is the aorta, right? So can I write aortic stenosis is the left-sided problem? Can I write, very importantly, coarctation of aorta? Very importantly, there's a block here. There's a block in the aorta. Coarctation of aorta, I can say. Interrupted aortic arch, I can say. Even mitral stenosis also, you can say. Mitral atresia, you can say, right? Exactly. Yes, very good. Yes, who is answering so beautiful? Dr. Amrit, hypoplastic left heart syndrome. Very classy, very classy, very classy answer. Hypoplastic left heart syndrome. Hypoplastic left heart syndrome also is a very importantly left-sided obstructive lesion which is dependent on the ductus arteriosus for the flow of the blood. And what is the name of the procedure? Last question. What is the name of the procedure for what you called hypoplastic left heart syndrome? Anyone? The surgery we do, no? This was a MRCPCH question. The name of the surgery for hypoplastic left heart syndrome. Anyone? Quick answer. Sophia, Suman, Priya, Amrit, Osama, Shubham. Yes. Have you heard of Norwood procedure? Have you heard of Norwood procedure? Norwood procedure is the name of the surgery for the hypoplastic left heart syndrome. And for TGA, anyone? For transposition of great arteries, the name of the surgery, what we do? Exactly. Have you heard of jet knee repair? Jet knee repair. Very importantly, okay. So jet knee repair is the name of the surgery for TGA. Norwood procedure is the name of the surgery for hypoplastic left heart syndrome. And this one, Nissen's fundoplication. Nissen fundoplication is the name of the surgery for Nissen fundoplication is the name of the surgery for GERD, gastroesophageal reflux disease. The name of the surgery is Nissen fundoplication. If I ask about Ramstedt pyloromyotomy, Ramstedt pyloromyotomy is the name of the surgery for anyone? Quick answers, please. Exactly, CHPS, congenital hypertrophic pyloric stenosis. So we have covered then surgery also, surgeries. Shubham, again तू मुझे याद दिलाएगा हमारी जो आने वाली किताब है. We have an upcoming book, Pediatrics by Dr. Anand, top 50s. In that one also we will mention top 50 name of surgeries. Norwood procedure for hypoplastic left heart syndrome. Jet knee repair for transposition of great arteries. Nissen fundoplication for GERD, gastroesophageal reflux disease. Ramstedt pyloromyotomy for congenital hypertrophic pyloric stenosis. Okay, very good. Perfect. This part is done. This part is done. Perfect. Yeah, and also now this is a beautiful, see now this is how, now the topic is a 5 marks question. Classify congenital heart disease. Congenital heart disease are classified into cyanotic congenital heart and acyanotic congenital heart. They can also be classified into a left to right shunts and right to left shunts, and they are also classified according to the right side pulmonary obstructive lesions or the left sided systemic obstructive lesions. And last classification is based on the parallel circulation. And the most beautiful answer on this planet. Can anyone tell me parallel circulation, where do you see? The answer is TGA. What is TGA? Transposition of great arteries. Transposition of great arteries. Exactly. Yes, exactly. Okay. Yes. Okay. Dr. Manish has a very beautiful point. Top 50 name of anesthesia drugs used in pediatrics. Yes, Dr. Manish. Top 15 nahi, top 50. Top 50, 50. We have a book, Pediatrics by Dr. Anand. Top 50, 50. Top 50 drug of choice, top 50 images, top 50 spotters, top 50 x-rays, top 50 instruments, top 50 viva questions, and top 50 name of the surgeries for various congenital hearts. Exactly. So parallel circulation, duct dependent, we everyone knows it is TGA. Last question. Now this class is over, guys. Yes, exactly. Dr. Suman, how can we get that book? Ooh, that book is a secret book I will not give you. I'm just kidding. I'm still making that book, my dear. It's going to get finished very soon. Then I will upload on Flipkart and Amazon. You can go and beautifully buy it there. Hanji, last question. Now, this is a good question. This is a good question. Yes. Name, tell me duct independent congenital heart. मैं मान जाऊंगा भैया, मैं मान जाऊंगा. I will be very happy that you are a very good student. This is the last question of this class. 1 hour 60 minutes are already over, bro. So now we have to finish this class now. Duct independent congenital heart disease. Tell me one, at least one, at least one. I'll be very happy if you can, what you called, if you can tell me. Yes, exactly. Dr. Pandey says top 50 pediatric complication. Shubham, तू लिख रहा है ना bro? Shubham, लिख के भेज मुझे. अभी पूरा लिस्ट बनानी है. मैं टॉप 50 की पहले बता रहा हूँ तेरे को. शुभम, तेरा काम है ये, ठीक है ना? एग्जैक्टली, यस एग्जैक्टली, परफेक्ट. पापा की सारी. हाँ, मैं वो है ना, उसमें बताता हूँ. 2 मिनट दो, बस 2 मिनट दो, बताता हूँ. एक एक दे दो अभी, बस गिव मी 2 मिनट्स, बस हो जाएगा. हाँ, ये पेन की है. हाँ, ये दे दो, ये दो दे दो अभी के लिए. ये पेन के लिए है. ये अभी मत दो, ये हम 1 घंटे बाद देंगे. ये कौन सी गैस की होगी? हाँ, ये गैस की है. अभी वो दो देते हैं, वो पेन के लिए. फिर खाना खाने के बाद दूसरे देंगे. दैट्स इट. ओके okay 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 Coarctation of Dr. Suman, coarctation of aorta, dear, it is a duct dependent congenital heart. No, coarctation of aorta, like the aorta is getting blocked. Coarctation of aorta is like a aortic stenosis, so the blood is not able to go from the whole aorta to my body. For the backflow, there will be a backflow, and for that ductus arteriosus will be good if I keep it open. Okay, so duct independent, yes, exactly, yeah, okay Shubham, that's great, buddy. So the duct independent congenital heart disease, very very important. Number 1 is truncus arteriosus. Beautiful answer. This is it's a new one. It's a new pointer for all the new and old students. Name some duct independent congenital heart where if I keep the PDA open also, it is of no help to the patient. The answer is number 1, truncus arteriosus. What is this truncus arteriosus, sir? Dear, truncus arteriosus means this. I'll tell you a quick diagram: right atrium and right ventricle, and left atrium and left ventricle. Truncus means this. Now this is known as a truncus arteriosus, where the pulmonary artery and the aorta, they club together. Pulmonary artery and aorta is like a single vessel. It's like a single vessel. Now this is known as truncus arteriosus. This is the first important point, because naturally, can we appreciate this point? Because if the pulmonary artery and aorta, you club it together, then keeping the PDA open, I don't think so it's going to be really helpful for the patient. Are you understanding? Because the blood is mixing so much already. It's like two vessels are combined in one. So PDA open, PDA close, it's of no use. That's a duct independent congenital heart disease. And very important, very beautiful point. The next point we have is very beautiful, is TAPVC, total anomalous pulmonary venous connection. Why TAPVC is a duct independent congenital heart? You know, right? Total anomalous pulmonary venous connection. Total anomalous, totally wrong. What wrong? Pulmonary veins connection. Normally from the lungs, pulmonary veins, they enter into the left atrium. The pulmonary veins, which has the oxygenated nice fresh blood, it enters the left atrium. In a case of total anomalous, totally wrong pulmonary venous connection, if I imagine, if the pulmonary veins are getting connected into the superior vena cava, are you understanding? This is only TAPVC, no, total anomalous pulmonary venous connection. If by mistake pulmonary veins are getting connected into the superior vena cava, can you appreciate more blood enter the right atrium, more and more blood enter the right ventricle, because the blood is coming normally also from the superior vena cava to right atrium to right ventricle to pulmonary artery, and now from the TAPVC side also to the right atrium to the right ventricle to the pulmonary artery. In this case, if I keep the ductus arteriosus open, it is of no use. It is of, can we appreciate this point? Let me know, yes or no. It is of no use to keep the ductus arteriosus open in a case of TAPVC, because all the blood has shifted to the right side of the heart, no? So keeping the PDA open, close, this, that, because if I keep the PDA open, everyone knows PDA is a left to right shunt or a right to left shunt. It is a left to right shunt, right? Because of the left side of the heart has a higher pressure than the right side of the heart, you know that, right? So even though PDA is a left to right shunt, there is no use of opening the PDA in a case of TAPVC. Are you understanding? Yes or no? Has everyone understood this much? Yes or no? Please let me know. Dr. Osama, Shubham, Manikandan, Wafa, Anum, Pandey, Vaishnavi, Vaibhav. Yes, exactly. And awesome me. Okay, is my voice audible to everyone? Please put a like button. Is everyone able to understand? I hope I'm making sense to you. Yes, that finishes this beautiful class. Has everyone understood this much? Yes or yes? Please let me know. Yes, okay, great. समझ में आ गई इतनी कहानी? Yes or no? Yes, Dr. Amrit is right. It is nothing but figure of 8 appearance, the supracardiac TABBC. Yes, brother, you're very, very right. That finishes this today's class. Thank you so much, everyone, for this beautiful participation. In the tomorrow's class, first of all, I'm gonna show you various shape of the heart, figure of 3, gooseneck sign, scimitar sign, egg on string appearance, signet ring sign, figure of 8 appearance, box shape heart, shmoo sign, and what you called panda sign, and money what you call water bottle shape heart. These are topics, all the signs we're gonna cover tomorrow. Beautiful pictures. Then I'm gonna start with properly one single shunts. Now we're gonna, in the tomorrow's class, we're gonna talk about separately ASD, separately VSD, separately PDA. The left to right shunts we're gonna cover, where I'm gonna tell you some important question regarding that, and we're gonna talk about, very importantly, atrial septal defect per se. Okay, has everyone understood this much? I hope you guys, I hope I've tried my best to teach you in a very beautiful way. I hope everyone has got the little idea out of it. Thank you, Dr. Shubham. That's very kind of you, bro. Very kind of you. Thank you, Suman. Thank you, Panchal. Thank you, Osama Sheikh. Shubhangi aayegi chali gayi. Dr. Suman, Grace, Shweta. Thank you, everyone. Before leaving, we always have a motivating quote, and today's motivating quote is, don't make the habit. Don't make habit out of choosing what feels good over what's actually good for you. Don't make habit out of choosing what feels good over what's actually good for you. What feels good, anyone? What feels good is watching movie on the Netflix. What feels good? Finishing all the season of Game of Thrones in one go. What feels good? Just sitting in the couch and doing nothing. What feels good? Sleeping for, I think, from 8 hours, 10 hours. What feels good? To roam around with friends and spending money and all that. This feels good. But the reality is, what is actually good for you? What is, can you please tell me what is actually good for you? What is actually good for you is, very importantly, a schedule is actually very good for you. A nice vision of your life is actually good for you, and a very well decent plan how to approach your vision and your schedule, that is actually good for you. So don't make habit out of choosing what feels good over what's actually good for you. Thank you so much, everyone, for this beautiful class. Good vibes, strong vibes to everyone. May God give you everything in life. Yes, Dr. Panchal says, watching Stranger Things. Yeah, me and my niece also, we are watching Stranger Things, but I watch like one episode in one day. That's it. That's more than enough. Okay, yes. What is actually good? Gym is good. Yes, having a routine is good. Yes, study, revision, discipline is really good. And you know that, right? You know that, right? You will never always be motivated. You will never always be motivated by people around you. So what is the solution for this? You must learn to be disciplined. You must learn to be disciplined, that this is my life. People can motivate me. Sometimes people are not available to motivate me or to inspire me. You will not always ever be motivated. So you must learn to motivate yourself. You must learn to be disciplined to have a very successful life. Thank you so much, everyone, for this wonderful participation. See you tomorrow. See you tomorrow, 8:30 p.m. 8:30 p.m. Okay. Tomorrow is Friday, guys. Tomorrow is the last class for this week. Okay. Monday to Friday. Our thought is Monday to Friday we're gonna cover, because Saturday is my night duty in my hospital. So Monday to Friday, very clear cut. We're gonna finish the cardiology classes, and our aim. Today is 7th, right? Our aim is to finish in the next 10 to 12 days. We're gonna finish the whole cardiology, and then of course I'm going to talk about congenital adrenal hyperplasia and all the crazy topics. But as we have started cardiology, it is our genuine duty to finish the whole cardio. That's what. Thank you, love you, take care, and bye bye. Take care, bye bye.